the doing online. So as you can hear, Aiden is assisting me in figuring this out. I'm Dr. David Shearer. I'm a clinical and prescribing psychologist, and I'll be doing some introductions of myself and all of us in a little bit of time here. So it's I'm used to doing in-person presentations and getting a lot of feedback by looking at people and getting nonverbal signals from people. So this should be interesting. So what I'd like to do is we're going to go ahead and get started. Let me tell you what the overall plan is going to be. I'm going to go ahead and start with my video on, so you get a chance to see me, see what I look like, and then as we sort of get into the meat of this, I'll probably drop my video off. You're probably familiar with this, but we're going to be taking breaks about every 50 minutes is the plan. I don't mind reminders if we get to that point and I'm chatting away and it's time for us to take a break. You feel free to let me know, myself or Aiden, and we'll do that. The lunch is at 12 to 1. Looks like our Zooms, we have separate Zoom invites or meeting codes for morning and afternoon, both Saturday and Sunday. You probably are interested in knowing more about the 7930 case presentations. We're going to go over that this weekend as well. Aiden has put together on Moodle a sign-up sheet so that you can start signing up for that. If you have any special requests in that regard, go ahead and let us know. I'm on the Alliant email now, so you should be able to find me there. We are also, time permitting, and I think I'm going to try to make this happen. I think at the end on Sunday, there's a training slide deck that I can go over that can show you sort of an example of how to do the case presentation, what we would like that PowerPoint to look like and what should be included and what you ought to be considering. And we'll also send you a copy of that so that you can look at it more carefully later. So by the end of Sunday, you should have a pretty clear idea of what it is you need to do on the case presentation. And if you have any questions, Aiden and I will be available for that. I like a lot of participation. I don't know if any of you have been at any of my presentations, but I do like to interact quite a bit. And I think this topic lends itself to participation. Again, I'm new to the online world, so how that participation happens isn't entirely clear to me. But I think there is a way to raise a hand. Is that right, Aiden?
Yes, they should have the hand option on the bar below the participants. If everyone are looking at the participant, they should have this option right there. They should have hand, yes, no, way to interact.
Make sure that you've looked at that and you know how to use that. You probably do by this point, but if you don't or you have any issues with that, go ahead and send a message to Aiden and he can help you with that. I'm going to encourage questions, so if you raise your hand, I think for the most part, I'm going to ask you to unmute and ask your question because I think that's just makes more sense than attempting to type out your entire question. And we'll see how that works. We'll modify as we go to see what works best for us as a group. The last piece of business before we get started is Dr. Steinman has asked me to put together an assignment for you sort of between the 7920 and 7930 courses. And so I know what that's going to be and what it's going to look like. I realize you were putting together your case presentations, and so I don't want this to be something that's incredibly time consuming, but I would like to make it valuable and interesting. And so by the end of Sunday, I will let you know what that is. And perhaps we should do that. I should talk about that by the end of today. So you have an idea of what we're looking at. Again, not something I'm expecting you to spend a tremendous amount of time on, just really an opportunity to think through some issues. Okay, at this point, I am going to go through the disclaimers, which I find the most boring part of this. And I am going to introduce myself, and then I'm going to ask you to each briefly introduce yourselves as well, since I haven't met you. You can tell me a little bit about who you are, what you do. I'm also interested, we are living in unprecedented times, and I am curious about how everybody is managing with the pandemic. I am, personally, I'm working from home these days, telephonically, and I suspect many others are as well. So before we get started, let's test out the question and answer thing here. So if you have a question, let's go ahead and ask those questions now. And I suppose what we can do, let's try the raising the hand thing and see how that works. Okay, guys? And Aiden, will I see something if somebody raises their hand?
Well, I am trying to figure it out whether it's a version of the Zoom that I'm having in the settings where I can add that option. For now, people have people can be creative and use the like a clap. It's also hand. As for raising hand, can you see mine?
I see your hand. Yep.
Right. So they can use that option as for a hand for now. We have yes, we have no, we have thumbs down, thumbs up, those kind of option for now. I'm trying to find the hand, but for now, I guess probably clap is the closest thing that come to the hand.
Okay, and I am looking at some of the chat in the background.
Right.
And I see that there's some questions about the PowerPoint. Yeah, don't worry, we're going to get to the PowerPoint presentation, the case presentation. It's due in 2 weeks, and we will get to that by the end of all of this. I have 3 new messages. Let's see how this works. I don't see any of those options. I notice my chat has another section. All right, so what we're going to do for now is, I don't know if everybody can see that Aiden has his clapping hands out. So you can either use clapping hands or just a hand. But since this seems to be, we don't know right now, you feel free to unmute and ask me a question if you have a question now.
No questions.
No questions. Thank you. Okay. And that's the other thing with the, you know, not on online where you can't see people. I don't know how long to wait. It's interesting.
The screen that I'm seeing has the main slide in the center, but then all of the power slides along the side.
Yes, I haven't clicked play yet, but that's going to happen here in just a second. Thank you. Yeah, and you're not seeing on my slides. I've got a couple of small windows open. You don't see that, right?
No, nobody see those.
Good. Okay, guys.
I see this. There's on the right and the left side, I see things, and then I see your top dashboard.
Okay. Well, now I just switched it over to play. So right now it ought to look like, hopefully you're just seeing the PowerPoint. Is that working for everyone?
Yes.
Okay, great. All right, and I assume somebody will say no if the answer is no for them. So this is the putting it all together, integrating psychotherapy and pharmacotherapy, which I feel really happy to be selected to teach this, because this is actually kind of my area of interest, and you'll see that as I talk about who I am, and we'll be able to really do a lot of applied psychopharmacology today. I want to acknowledge a few people who've contributed to these slide decks. I inherited about 200 slides, and I have expanded it to about 404. And yeah, we'll see how that goes. That's a lot of slides. I will pace it. There are some things that we can move through relatively quickly, and other things I'd like to spend some time on. But credit to these folks who also have put some time into this training for you. This is probably my most important disclaimer. I work for the Department of the Army, the Department of Defense, and I am not speaking on behalf of them. I am speaking as a private citizen. Sadly, I have no financial or other interest in any commercial companies relating to this activity. You can read these disclaimers. I don't need to read them to you. I'll give you a few minutes to look at them and see if you have any questions about this. I'm working on getting the award for the highest number of disclaimers in any lecture series. You notice that bottom one, I'm not endorsing psychologists or other people to practice medicine without a license. That is true, but I'm hoping you all are going to be prescribing at some point. That will not apply to you. The next page here. If you are at some point going to be lecturing on psychopharmacology, I recommend that you borrow and adapt these types of disclaimers sets for your future presentations. As far as citations and references go, pretty much I can tell you where anything comes from, and I think they are listed at the end of this. If there's anything that you can't find, let me know and I will find it for you. I often have the original article and can send that to you as well. Okay, let me start by talking a little bit about who I am and how I ended up here. So my wife is also a psychologist. I went to school at Utah State University for my PhD. I have a master's degree from the University of Idaho in clinical psychology. I have a master's degree in school psychology from Utah State University, as well as my PhD. And then somewhere around 2003, I realized that my student loans were too high, and I decided to move to essentially the Navajo Reservation and work for the Department of the Interior, where I was able to get loan repayment. That turned out to be an absolutely fascinating and incredible experience for my wife and I. If you ever have an interest in that, I'm happy to talk to you about that later. We spent 4 years there, but that happened to coincide, if you notice the dates, pretty much with shortly after the New Mexico being the first state to pass the law to permit prescribing psychologists went into place, and it turned out that I was quite interested in that, and I started taking their master's degree program shortly after I got there. So after 4 years, we moved to Washington State, where I work now. I work for the Department of the Army through the Department of Defense. I'm a government employee. I work at Madigan Army Medical Center, which is a hospital at Joint Base Lewis McChord, which is near Seattle. It's a very large base. It's like the second or third largest base, and it's combined with an Air Force base as well. It's a large hospital. When I came here, we had a friend who was working here, was trying to get us to come out. There were jobs for both of us. They were in a hiring frenzy at that time due to the wars that we were fighting. And when I was hired, they decided to place me in family medicine. I had just completed my PEP was done. I had just completed my 1 year of supervision with a psychiatrist in Gallup, New Mexico. And I had a job offer in Farmington, New Mexico to work as a prescribing psychologist in a primary care group, which was super exciting. I was very excited about that. My wife and I, we had just had a child, and we decided that Washington was better suited to us raising a family. And so we came up to Madigan Army Medical Center here in Washington, and I had no idea if I could prescribe or not, or if they would let me. There was, some of you may know, in 2009, there was a Department of the Army memo signed that was permitting prescribing psychologists to work in the DoD. That's another story, but eventually they placed me, well, not eventually, right away, they placed me in the family medicine department. Again, apparently I was destined to work in family medicine. I had no idea at the time what an amazing location that was going to be for me to work. That has become one of my primary interests, is psychologists embedded in primary care, particularly prescribing psychology. And it's been just an amazing an experience there. I've been there for about 11 years now. And I won't give you the bloody stories of getting my prescribing credentials there, but let's just say that there was a bit of a fight. The chief of the Department of Psychology at the time had to go to bat for me. You think that you sort of got it all going when you've got you're permitted to prescribe, you have a certificate, but that's not always the case. You have to remember that whatever hospital you're working for, whatever system you're working for, they have a credentials committee. And if that credentials committee does not allow credential you to prescribe, you do not prescribe. So my big burning hoop was to get through the credentials committee. And the first time that they presented me and then we went through that, the psychiatrist on the credentials committee said that they should not credential anybody who only had a weekend of training in psychopharmacology. So I hope right now you're laughing about that, because you are going through this program right now, and you know this is a tad bit more than a weekend of training. So we went back to base and we fought the battles, and a part of it was being integrated in family medicine. I had a tremendous amount of support from family medicine because, as you know, family medicine is prescribing a lot of these medications, and they suddenly had a psychiatric prescriber who they could consult with and work with, and who would take their patients who were treatment resistant or very difficult and challenging for them, and they wanted to promote that. So I was able to get credentialed. You can see my research interest there. I really am all about combining psychopharmacology and psychotherapy. I have no interest in being a mini psychiatrist. I really am a psychologist first who also prescribes, and I really believe that's a huge strength of what we bring to the table. I can't remember if where my faculty stuff is, but let me just say, so I am a core faculty member of the Department of Family Medicine at Madigan. They train about 20 physicians to be family medicine docs a year. And each class has about between 6 and 8 physicians who are trained. If you know much about residency training, basically they're out of medical school, they're doctors, but they haven't specialized yet. And so I am the director for training for that. And that is, so I've had about 10 or 11 years of residents that I've been training in family medicine who now think prescribing psychology is a pretty good idea. So that's kind of nice to have those folks out there. So that's my primary role as Director of Behavioral Sciences. I also am on the faculty for the psychology internship and residency program at Madigan Army Medical Center, and I teach a 1-year psychopharmacology course once a month. I go in and then I beat them up for 3 hours on psychopharmacology. So some of them love it, some of them tolerate it. Alliant University just hired me to teach this course and the 7930. I'm an assistant professor of family medicine through what's called USIS. I didn't hear about this. I didn't know about it before I was part of the Army family, but it's basically the university for the armed services. It's a very good university. We're clinical instructor at Washington, University of Washington, in family medicine as well. On the side, I am the chair of the Prescribing Psychology Task Force for Washington State, and I'm happy to say that we have a bill sponsor, and we are planning to drop a bill in 2021, and we're on target for that. We have a lobbyist, and we are going to be presenting to the committee, the Health and Welfare Committee, this summer. So we'll see how that goes with social distancing. So I'm not sure how that will happen or when it will happen, but hopefully sometime this summer. And I'm on the Hospital Ethics Review Board as well. All right, so that is me in a nutshell. I would like to go to you guys, and I think probably the way to do this is I'm gonna go ahead and see if I can't pull up my list of participants, and then I'm just going to go through, if you guys don't mind, in order of how I see this, and it's probably how Oh, it looks like it's alphabetical. So I'm going to do this how I'm seeing it, and I'll just call on you. And then I'd like you, if you want to show me a picture so I can see who you are, that's fine. If you don't, that's cool. You might still be in your pajamas. And then like you just kind of give me a brief introduction of yourself as well. All right. So is it, I believe it's Edie, but you can correct me on that. Taylor, would you like to start? So,
I think you mean Eddie,
Hi.
Eddie Taylor?
Eddie Taylor,
Can you hear
there we
me?
go. Eddie
Hello?
Taylor.
Hello?
Hello, Dr. Taylor.
He says he has no microphone. It's in the chat box.
It's in the chat box. Okay.
Yeah, he says no microphone.
No microphone. All right. I'm not even sure how I got the chat last time. Let's see here. There it is.
Mateo says he can't talk because it's 2:23 a.m. I think he's over in Hawaii, maybe. He got to wake up his wife and kids.
Fair enough. Okay. Abdullah?
Hello,
Hello.
my name is Abdullah Nuristani. Professionally, I'm a pharmacist residing in Sacramento, California. And a good news and a bad news. A bad news is that I recently tested positive for COVID-19.
Oh,
Yeah, and me and wife together.
oh boy.
Yeah, and good news is we are recovering. It's almost 2 weeks now. So in a process of getting better, energy levels are going up, symptoms are gone, and so we're dealing with that aspect of COVID-19.
Wow. I am so glad you guys are doing okay. That is terrifying. Wow. Okay. So did you guys get pretty sick?
Oh yeah, a lot sick. Interesting thing was it was for wife wasn't a typical symptoms.
Yeah.
He had just only coughing, and I had just only low-grade fever and body ache. And I have had almost for 12 days of a constantly fever. I was barely can walk, and then lost a lot of weight, obviously. And now we are lost sense of smell and taste for my wife. I had a little bit left, but my wife completely was gone. But thanks God, we are now recovering. We're good. We're good. We're still I'm off from my work. It's almost 3 weeks.
Yeah.
I'm planning to take probably another week to get my strength back and fully functional. But the wonderful system and health that we have in our country, that they are not testing us. I had to fight tooth and nail with this system that to test me, because I wasn't part of this, those criteria that I am able to go and get a test done, because according to them, I am not qualified because I have just only fever, stay home, and body ache, and those are not part of that. And then later on, I managed to fight with them, and then tested me because I've been telling them I am contacting with the people because I'm a pharmacist.
Right.
And then I have working with the 45 people in our pharmacy. But so finally it got tested. Obviously it was expected, it was a positive, and then wife did it too. Same thing. Now we are basically, the symptoms are gone. Now I'm fighting again with them to test me. So we at least, I know that I'm completely okay and negative, and therefore I could have my kids back home, because I
Right.
sent my kids away. and I cannot go to work consciously, I just wanted to know that I am completely negative. So this is where we're standing.
Wow. Okay. But you are living this now, right? I mean, that's amazing. The resistance to testing here in the Department of the Army. One of my residents got it. Now and he was, when he was in the ICU, he got exposed, and they've been testing and retesting him. You know, actually, they've been retesting him daily for the last 3 days. So, you know, there's kits out there, and it needs to be done. And I don't know why they wouldn't consider a pharmacist a healthcare worker. That's nuts. But thank goodness you guys are both okay, and hope you continue to recover okay.
Thank you. I appreciate it.
Yeah, and welcome. Glad you're here.
Thanks.
All right. Well, thank you. Amanda, I'm going to have you be next if you can.
Am I unmuted?
You are unmuted.
Okay, great. Hi, I'm Amanda, and I live in Los Angeles. I have my primary job is working as in private practice for about 11 years now, and I do only psychodiagnostic testing.
Mm-hmm.
ADHD, learning disabilities, the like, primarily with school-age children, but I also do some accommodations testing for high schoolers or who are getting ready to take the SAT, ACT, or sometimes even for adults who are taking the LSAT or MCAT. And I used to do child therapy, and when I probably for about the first 6 or 7 years in private practice, and then my testing practice grew so much that I was finding it difficult to do both. So I sort of switched over to just doing testing, which has, in this what we're going through right now, has really hurt me.
Right.
Because everybody's doing telehealth now with their therapy clients, and I can't do any face-to-face testing.
Are you trying to use VTC at all for that?
No, I'm not even familiar with that.
Yeah. I know our neuropsych department was trying to do some things that they thought they could do with VTC, but I'm pretty sure that during this period of time where we're all working from home, my colleagues in neuropsych are just hanging out. But
Right.
now we're government workers, so we're getting paid.
Right.
So it's not the same. So that is super challenging, right?
It is. You know, with testing, there's always like this cycle of some are in the testing phase, some are in the report writing phase. So there's checks in the mail, so to speak. But, you know, at some point, if this goes on long enough, the checks aren't going to be in the mail anymore.
Right. There's going to be a big empty period where checks aren't.
Exactly. Right.
Yeah. Oh my gosh. Well, welcome. I'm glad you're here.
Thank you. Looking forward to this.
Amber? Amber, are you able to engage with us? Let's see. Sorry, sick today. Okay. So Amber, we're going to skip Brady.
Good morning.
Hey, good morning.
How are you?
I am good.
Licensed psychologist in the states of California and Arizona. I'm the regional medical advisor for Social Security disability.
Okay, great.
Meaning I look at records and offer opinions on benefit eligibility.
Yeah. Okay, great. And in Arizona and California?
Yes.
Are you in Southern California?
No, up in the Bay Area, San Francisco.
Oh, okay, yeah. I grew up in Petaluma.
Oh, right across the bridge.
Yep, kind of. I know that area, and I in my perfect life, I also live in Arizona or New Mexico in the wintertime. So,
Yes. Definitely not the summertime.
well, welcome. Good to have you.
Thank you.
So let's see. Brian?
Can you hear me?
We can hear you.
Okay, I'm a licensed psychologist in Hawaii and Florida. Spend most of my time in Hawaii in private practice. There's quite a bit of military out here, so do a little bit of that and just general population.
Wow. Okay. Hawaii and Florida. Were you unable to find any places that were further apart, or?
I grew up in Hawaii and just happened to go to school in Florida.
Oh, okay. All right. Yeah. Well, two beautiful places. And of course, Judy's now in Florida, right? From Hawaii, Judy Steinman. So,
Okay.
All right. That's great. Love Hawaii. All right. And Carmen?
Okay, so I'm gonna be daring and I'm gonna show off my face. So hi, I'm Carmen Pulido. I have the best job ever. I also work for the federal government, so I'm working with NASA, and I also teach. So I teach in California, and I do my NASA work here in Houston, Texas. And I've been working full-time, both jobs. Like I've been working from home for the past 5 weeks. Next week, when I start on Monday, it'll be my 6th week.
Wow.
And I'm going a little bit nuts.
I was going to say, how's that going? Yeah, it's a little cabin fever.
Yes. It's it's kind of crazy. Never experienced anything like this. Like in the back, gosh, in 2003, we had like the fires in San Diego.
Yeah.
You know, all that area where we had to stay at home, but it was just a matter of days. So it just kind of, it's very strange. And even though I'm very fortunate to be working and being busy and having things to do, it's still stressful, which is, you know, just, you would not think so, right? Because I know that for people who are not working, that it's, you know, an additional thing to be concerned of. But it is such a weird thing. And I think many of us are so accustomed to be busy and doing things, and not doing so. It is a very strange experience.
Yeah, that's a good way to put it. And I have little kids. I have twin 9-year-olds and an 11-year-old who are at home. My wife's also a psychologist, so both of us are working, teleworking, and supposedly educating our children and caring for them at the same time. And you know, we're pulling our hair out.
Yes, I know.
never thought I would say I can't wait to get back to work, but
yeah.
I can't wait to get the kids back to school. So, well, welcome. And at some point, I'll have to ask you about your job at NASA. That sounds fascinating. So,
Absolutely, yes. Nice meeting you.
Chiara, are you able to join us? Or did I already say that you could not? From Chiara to everyone, neuropsych, psychotherapy, research, and disaster psych. That's much needed at the moment. And Chiara, I'm assuming since we got that from you, that you probably don't have a mic, okay? I'm gonna assume that unless I hear from you. Danielle?
Hello. I'm having a headset issue, so can you hear me?
Yeah, we can hear you good.
Okay. Can't really see me at the light back, sorry. So yeah, I'm a licensed psychologist in the Bay Area as well. I live in Oakland and run a large treatment center, primarily is my primary position in on the peninsula. And so dual diagnosis, residential, IOP, outpatient, aftercare. We're still taking clients in, so we're quarantining people, and it's a whole thing. I am officially now the last clinician going in, so I guess I'm kind of the lone survivor at this point. I also, my partner and I are both essential employees, so we're working more than ever. And my 6 and 8-year-old, I'm talking quickly because they're going to come in any moment. So my 6 and 8-year-old are being homeschooled. I'm not a good homeschool teacher. Legos are definitely happening more often than homeschooling, but you know, there you go. So our clients are really, we have about 60 clients in all right now, and they're really, really struggling a lot. They're, having visits, doing a lot of telehealth, things like that, and they're getting visits with family via video, but a lot of decompensation, especially with the folks with significant mental health issues and trauma, is getting kicked up. So it's been exciting. I'm hoping to find time to finish to do the final presentation. So now I'm going to turn off my mic before my kids blast it.
Your kids can talk to my kids because they're going to burst in at some point. So
I know. Well, you'll see. You would have normally seen a face. I'm surprised one didn't show up here, but thank you.
that sounds your life sounds intense. I will just put it that.
All right.
Intense.
All right.
Okay, and now we had Eddie and Eddie. I have Eddie and Eddie Taylor on here. If you are two different people, one person did not have a mic. Does another person have a mic?
Yeah, this is just regular Eddie. I was fighting up at Fort Lewis. That was my first duty station a long time ago. So
Where was?
Fort Lewis.
Oh, was it? Yeah.
Yeah, I was first of the 23rd Infantry back on the other side of the airfield.
Nice.
We're kind of notorious back then. We had a lot of trouble.
Yeah, I heard about you.
Now I work. Now I work at the VA here in Colorado Springs, real close to Fort Carson. So still kind of around the area. Almost took a DoD position for embedded behavioral health there at Fort Carson. It was kind of between the two.
Yeah.
Working at the VA, they gave me a student loan repayment, and I could also teach at the local university. So I kind of went that direction for now. Yeah, I guess that's about it. We haven't been too affected here. I'm still going to work every day. We're also kind of doubling down to try and help out to provide support for the emergency, physicians and people working in the ICU.
Yeah.
They haven't had as much of a need as they're predicting, so that's a good thing.
Yeah.
So, but other than that, we've been relatively untouched as far as we know.
And as far as you know, is probably the right way to put that. Do you happen to know there's a prescribing psychologist at Fort Carson, Brian Seavey? Do you know him?
No, I don't. No, I don't really know all of the prescribers there. I just moved here from I was living at Fort Benning before I came here.
No, okay. Yeah, I think Fort Carson. Fort Benning personally.
So I heard
yeah.
yeah. It's Fort Benning. That's where I started my military career. I was infantry guy, so that's the home of the infantry. So it was nice to return home and.
Were you enlisted or officer?
No, I was enlisted. I was actually here at Fort Carson. I was the infantry squad leader. Kind of deployed. Came back and got out and decided to I got really interested in PTSD, and so then I started studying PTSD and started going to school, and then not to be expected by most grunts, I actually started to do pretty well in school and kind of kept going, and then kind of been in school for like over a decade. So
yeah.
It's worked out pretty well.
Well, awesome. Well, welcome. That's good to have you.
Well, thank you. I appreciate it.
All right. And I've got G. Datz.
Good morning. I'm Jerrin. I live in Mississippi. I'm originally from New York. I moved down south about 15 years ago. I'm licensed in Mississippi, Louisiana, and Alabama, and I have one of those SIPACT licenses, so I have the ability to do telehealth in about 6 other states as well,
Nice.
which has been kind of handy lately.
Yes.
I run a behavioral medicine practice here, and I have a number of other clinicians that work with me. It's been a pretty stressful time. I go to work every day. We do telehealth, and we do some urgent in-person appointments because we work with a lot of physicians and surgeons and such like that. I had a life-saving emergency bariatric eval the other day where we were both masked and in PPE. So anyway, I'm definitely not bored, but I'm tired.
Yeah.
And as a business owner, there's been a lot of uncertainty with everything going on, but I'm hopeful that everything will kind of calm down soon.
Yeah. Okay. So intense financial stuff and doing an evaluation and full PPE. That's interesting.
Yeah, yeah. Well, I don't know how full it was, but I mean, I had what I had. You know,
Like a bandana and sunglasses or something, or
yeah, a little face cover, you know, the shield, but I didn't have the full hazmat or whatever. You know, she was. I mean, we were. You know, she was tested and we had temperatures and all that. And I don't know. I don't know whether it's. I'm just in it, so it doesn't bother me as much. I'm not as worried, you know, when people are, but I mean, you know, on the other hand, you never know. So I've been fine. I've been actually doing evaluations in person and telehealth since the end of February. So kind of before the wave hit, we were kind of hearing about it and preparing.
good. Well, good that someone was ahead of the curve. Well, welcome. Good to have you.
Thank you.
Heather?
Good morning. I'm a psychologist in Milwaukee, Wisconsin. So I am the behavioral sciences director for the Medical College of Wisconsin Family Medicine program. So I'm working a lot with residents and faculty as well.
Yeah.
Right now I'm doing a lot of teletherapy, but a lot of my job is trying to help the faculty and the residents get through this COVID crisis because they're working with a lot of patients that are testing positive. In Milwaukee, it's disproportionate number of cases of COVID compared to the rest of the state. And so our hospital is seeing about 80% of those cases. And it's just really tough. A lot of residents are going through pronouncing their first deaths. And I've been doing a lot of wellness groups at the hospital. So it's been a very busy time for me.
Yeah, you're in the thick of it right now, and that's which residency, which specialty?
It's family medicine.
Family medicine. Yeah, family medicine really ends up being at the forefront a lot, right?
Definitely.
And it's very intense.
It is, but it's a very interesting job. I really like it. I'm working right now with a lot of physicians on consulting on psychotropic medications. I know I can't prescribe in Wisconsin, but I'm hoping that this will help to give the providers more direction and engage with them in treating mental health issues. So.
Well, if it's anything like my experience, they're going to love it, right? I mean, they just love having someone they can go to. Yeah, we'll talk more about that. But yeah, I can see that being super valuable. So, well, welcome and
thank you.
Glad you're here, despite all the stress and busyness. So.
Thank you, and thank you for being here.
Jason. Jason, are you there?
Can you hear me?
Just a little bit. Say something again.
Testing. I don't know what to say. Let's see. Is it like super quiet?
No, you're loud now.
Okay. Apparently, I just need to hold it right in front of my face. So I'm Jason Christofferson. I actually graduated with my bachelor's degree from the University of Utah, so right up the way from where you were at.
Yeah, fantastic. I lived in Salt Lake for a while. Loved it there.
Yeah, and then I also I was a missionary in Tacoma, Washington, and was living for a little while in Steilacoom, right next to where you're at. So that was kind of funny.
Yeah, I feel like you're like stalking me or something.
Apparently. So I am a psychologist in Fresno, California. Last year, I had the opportunity to finally finish getting my board certification in child adolescent clinical psychology. So that was nice to be done.
Fantastic.
I work with children and adolescents. I do psychotherapy and also a lot of psychological testing and neuropsychological testing. So I really enjoy doing both of them, and I don't know that I could ever like just do one of them. So for those who can, I applaud you.
Yeah.
But yeah, I live in Fresno. That's where I grew up and then left, and it dragged me back because everybody claims it's like a black hole. And then let's see, I'm pretty sure that I'm the assistant clinical director and director of training at a private outpatient clinic here in Fresno. So unfortunately, I don't qualify for pretty much any of the student loan repayment programs because I work for a private company instead of a nonprofit or governmental organization. But you're welcome for everyone else because I pay into all of those little student loan repayment programs that you guys get to take benefit from.
Hey, thank you. I'm gonna send you a fruit basket or something.
Oh, okay. That'll be great. All right.
All right. Well, hey, okay. Thank you, Jason. Good to have you here. Joy?
Hi, everyone. I am a psychologist in Connecticut. I am the director of eating disorder services in a substance abuse rehabilitation facility. So we are all working from home right now, doing virtual IOP and outpatient appointments. And it's actually been a nice break for me where our dietitian is leaving. So we're not running the eating disorder IOP right now. So I'm just seeing individual patients, and we have a lot of people relapsing, a lot of people really struggling with eating disorder symptoms right now as they're all kind of cooped up in their sober living environments and struggling with all their mental health stuff. But we're all kind of plugging along, and I'm actually shocked my dogs haven't started freaking out yet. So silence for 5 minutes.
So your dog, you're like, yeah, they're the canary in the coal mine. Things are bad if your dogs start freaking out.
Yeah, I'm kind of wondering what they're doing, that they're silent, but I got 5 minutes of silence, so it's good.
So did I hear you correctly? So you do eating disorders within a substance use disorders program?
Yes, there's a high correlation between eating disorders and substance use. About 50% of people with an eating disorder will meet criteria for substance use disorder, and about 30% of people with substance abuse will meet full criteria for an eating disorder. So this is kind of a widely known fact, but for some reason, a lot of treatment facilities won't treat them together. So we have decided that it makes the most sense to treat them together, as there's a lot of similarities. And I think it works pretty well.
Yeah. No, and I could see how they could feed off of each other. So if you don't treat one, you're just begging for trouble. But
it's all to be coping. We call it whack-a-mole. Once we get the substance abuse under control, the eating disorder flares up. And then once you work on the eating disorder, the substance abuse flares up.
Oh, interesting. Okay. Well, welcome, Joy. Good to have you here.
Thank you.
Kayla? Kayla, are you able to talk to us? You may be going to see what your dogs are doing also at this moment. Hey, Kayla, if you can join us, let us know. I'm going to move on to Kirsten. Can you talk to us? Oh, wait, from Kirsten. Don't have mic video. And she gives us a little bit of a background on her. PCPs are already asking her for advice. She's doing mostly telehealth or crisis work with some in person. Okay, cool. All right, thanks for sending that. Maribel? No microphone. I work in the LA County Jail, men's and women's. I work with felony incompetent to stand trial. I also have a small private practice. All right, Maribel, thank you. Welcome. Mateo? From Mateo. Hi, I'm a clinical psychologist and currently live in Sydney, Australia. Oh, cool. Even if I'm still licensed in the state of Colorado, I work at a counseling center of, I won't even try to pronounce that, McCary maybe University, but planning to move on and eventually work in a hospital once I accrue 10 years with my current employer, as it comes with 3 extra months of paid annual leave. Yay. I am 2.5 years away, working from home because of COVID, and the situation in Australia is not too bad. All right, Mateo, welcome. From far, far away. That's cool. All right. Monica?
Hi, I'm Monica Downey. This is my disheveled work from home look. It's starting to take over every day. I am a psychologist in Arizona. I'm also licensed in California. I moved here, I think Brady said the same thing. I moved here about 1.5 years ago. I work for Iora Primary Care doing geriatric population right now. So I direct their Arizona program. It's a great company. I'm really enjoying it. It's also not fee-based. It's more membership-based. We partner with Humana, so which is kind of good because I have a job because of that, because we're not fee-based right now. So
It's not a bad thing, right? Okay.
Looking forward to the class though.
Oh, great. Well, welcome. Hey guys, I noticed that it's 9:52. Is everybody okay with us finishing introductions and then taking a break? Let me suggest this. Let's go ahead and do that. But if you need to take a little break or something like that, go ahead and do it right now. But we'll take a real 10-minute break here in a few minutes. Najib, can you talk?
Yes, can you hear me? Hello?
We can hear you.
Okay, yeah. Hi, doctor. Yeah, my name is Najib Rahmani. I'm a pharmacist. I work in a closed door pharmacy. So the good thing is I don't really have to worry too much about the stay-at-home issue because we don't have that much contact with patients. But my specialty is mainly we deal a lot with psychiatric patients. We're contracted with what we call psychiatric health facilities or PUFs,
okay.
Which are patients who are, it's pretty much an inpatient setting. So we deal with a lot of those patients and geriatric patients as well. So that's why I have this interest in psychopharmacology, and
yeah.
I want to just pursue this, even further.
Oh, great. Well, it's great to have you. 2 pharmacists in this cohort. That's terrific.
Thank
okay.
you.
Well, welcome. Let me see here. Rebecca, have we already talked to you? I don't think so.
No, not yet.
All right.
Towards the end of the alphabet. I'm in Pennsylvania, a rural area called Bedford County. It's about 2 hours east of Pittsburgh.
Okay.
And my husband and I moved here a little over 1 year ago from Florida, and everyone thinks that I need a psychologist. But we're both originally from the Pittsburgh area, so we decided to be back closer to family.
Nice.
When I was in Florida, I was working for an FQHC. And now that I'm here, I opened a private practice, but I'm finding that because it is more rural, more spread out, there aren't as many people who have third-party insurances. And I had determined that I wasn't going to take Medicaid after I left Florida. But I'm now looking into possibly signing on with a company that does VA claims by telehealth.
Yeah.
And just giving up pretty much the private practice, because I don't think in this particular area, I'm not sure it's really going to be worth, struggling with it. I'm spending more money than I'm making.
Yeah, just not sustainable. Yeah.
It's not sustainable. I mean, I love the patients I have. They're very committed. However, there just aren't enough. And the one good thing, though, is that because it is a smaller area, primary care providers, because not all of them are doctors, really have consulted and depended on my recommendations for medication.
Yeah.
And so that's been a really nice relationship.
That is really nice. That's great. And we're going to talk about that some too. Okay. Well, welcome. Robert?
Good morning.
Good morning.
just what we needed. I live and work in Canada. I have worked in American jurisdictions as well. For over 40 years now, I've worked in basically corrections or forensic psychology or psychiatry institutions. I'm 60 days away from retiring, so I really don't know what I'm doing right now, but anticipate that I'll use this information in a private practice situation starting in the fall.
Great.
We have no problem with the COVID virus where I live. In the area I live, we live quite rural outside of Calgary, Alberta, so it's fairly safe where I am.
Good.
However, I am stuck at home. For the last 10 years, I've done incident investigations for the Correctional Service of Canada. And basically what that means is I travel around the country, visiting institution after institution when there is either a death by suicide or a death by some undetermined means. I spend a lot of time in those facilities and a lot of time in inquest hearings. So looking forward to staying home with my dogs in about 60 days.
You're ready to get out of prison?
I never thought it would happen, but I've aged out.
Well, welcome. It's good to have you. You look like you have the command and control center behind you there. So
actually, the desk behind me is a reflection of my cluttered mind. So just excuse that.
Yeah, my clutter is in front of the camera, so you can't see it. So welcome, and I think I'm not sure I can say your name right. Sarub, is that correct?
Sarab.
Sarab?
Yeah.
Okay, hi.
Hi. Good morning and afternoon for some of you all. I am a licensed psychologist in California. I am also a neuropsychologist. I am extremely grateful to be one of the lucky ones. I have I own a mental health practice, a group practice. And so I shifted all of my staff over to telehealth around March 16th. And so we've been able to, I've been able to keep my staff employed. I've been able to have income kind of continuing to flow in for me. I don't have a very large personal clinical caseload. So I'm so grateful to be in the position I'm in. And my heart goes out to folks that are struggling economically, struggling health-wise. I obviously I'm very conflicted about the good fortune I have, but I'm trying to figure out ways I can help folks with the position I'm in. In my clinics, we offer services to commercial health plan folks with commercial health plans, as well as with our state's Medicaid program called Medi-Cal. So that's at least one way I console myself that we're doing something, but I'm looking for other ways I might be able to help in this circumstance. Finally, I'm also a president-elect of the San Diego Psychological Association. So next year is my big year. And I know this is a subject I'm going to be tackling during, I guess you can call it, my administration.
Yeah, absolutely. Well, welcome. And so you're in San Diego as well, huh?
I am.
All right, great.
Thank you.
By the way, I went to school in Santa Barbara, so kind of
Oh.
near you guys. Love the
Kind of new, yeah.
There's a couple of people that are listed as WXYZ. I don't, if that is somebody, is that somebody?
It is. That's me. Unfortunately, you can hear an echo because I mirror from my laptop, but I respond from my cell phone.
Oh, okay. No worries. We can hear you okay. Tell me your name.
I'm sorry, what did you say?
What is your name?
I can't say my name because I'm the only one in the department with it. So if I say it, my supervisors will know.
Got it.
Unfortunately, they are not supportive of my participation in this program.
Got it. Well, we'll let you cut out. Okay. We'll talk to you later.
Okay.
All right. Bye. Is there anybody that I've missed? Okay. I'm going to assume that is we have not missed anybody. Let's all take a 10-minute break. I'll set my timer for that, and we'll dive into the material. Okay. Great to have you all on board. Nice to meet you all. You're an impressive group. Looking forward to working with you on this subject. All right, guys. We'll see you in 10 minutes. All right, Aiden, are you there?
I'm here, Doctor.
Okay, so I'll be back in about 10 minutes, all right?
Sure.
Okay. We're ready to be back online and rocking and rolling?
We are, and before we go too much into the material, I was wondering if I could ask a quick question.
Yes, and who is this?
This is Eddie.
Eddie, okay.
With the, how does the pay scale work with you being a prescribing psychologist for the Army? Because in the VA, they haven't moved that way yet, but I'm hoping they will, but I'm not sure what it looks like. That's one of the psychiatrists that's kind of in charge had mentioned, was not sure about how the pay scale would work. So I was just a little bit of curiosity how it works for the military.
So it's an interesting question. Right now they're hiring, they're not doing anything special. We don't have a specific job description through HR, although I do have a specific job description for me. I am a GS 14 because one of my supervisors had the foresight to try to get that through about 8 years ago. And we have tried to convince the powers that be that prescribing psychologists should be hired at GS 14s, but currently they're being hired at GS 13s. And that'll be something that we're going to continue to push. And I think that the more of us there are, the more likely that we'll be able to see a 14 out of that.
Oh, well, thanks. I appreciate that.
Yeah. Yeah. It's very frustrating. That's a very sore point. And it's a little frustrating for me. But it's one of those battles that's won from within rather than without. My experience has been that once we demonstrate our utility and our skill set, and then we ask for the GS-14 job description, I think we're more likely to get it that way. That's essentially how it happened for me, is that they were like, well, yeah, you provide a tremendous amount of value-added skills, and we ought to do that. But to just do that right off the bat, there's just not enough prescribing psychologists in the Department of Defense yet, or the VA. Well, obviously not the VA, because we haven't done that. We haven't cracked that nut yet, but we will eventually, I think, when a few more states go. All right, everybody back on board and ready to go? Seeing some yeses. There's a question about PAs and NPs. So I had a friend who was a psychologist and a psychiatric nurse practitioner, and they paid her at the psychiatric nurse practitioner pay scale, which is GS-11, and she eventually left because of that. And she was amazingly skilled, and a child psychiatric prescribing psychologist, which we desperately needed. So yeah, that was very frustrating. So there's not a lot of foresight in this, but we're working on it. All right, guys, so let's go ahead and we're just going to dive in and get started. I probably don't really need to give you guys rationale for prescribing psychologists. You know what they are. You wouldn't be involved in this stuff, but let's cover it briefly here. Obviously, there's lots of unmet need out there, and particularly low SES, impoverished areas, rural areas have much less access. Psychiatric providers, not unlike other providers, tend to group around urban areas because there's plenty of work and the pay is good. There's not a lot of impetus to work in the rural areas. You probably are aware that the psychiatrist workforce is shrinking. More than half of psychiatrists are over the age of 55. Many are moving towards retirement. They're having trouble recruiting psychiatry residents. So they're kind of losing psychiatric providers from both ends. By the way, just kind of a disclosure, I have no animosity towards psychiatrists. We need them. We need more of them. And I've had a good relationship with psychiatrists in the past. My general experience is that they're very supportive with me one-on-one and personally. And then on the bigger picture, it's hard for them to support prescribing psychology because it's kind of a scope of practice and turf issue. But as I always say, there's plenty of turf out there. There's so much need. There really is no competition for it. Again, who's prescribing all these psychotropic medications that we're going to be talking about? Well, mostly primary care docs. Yes, a lot of the more maybe mood stabilizers and atypical antipsychotics and whatnot are being prescribed by psychiatric providers, but the vast majority of psychotropic medications, antidepressants, benzodiazepines, Z-drugs, etc., it's really falling in the lap of primary care. And even some of these cases of atypicals and mood stabilizers, my primary care providers are coming to me often. They're like, hey, I'm getting this patient who's bipolar and they're taking Depakote and lorazepam. And here are the doses. Does this make any sense? Should I continue this? Where should I go with this? And if I wasn't there, they just have to figure it out. So primary care really takes the brunt of this, and in my view, should be one of the biggest supporters and often are of prescribing psychology. We know as psychologists that combining medication with therapy often improves outcomes remarkably, particularly in terms of kind of long-term relief and long-term change. Let's see. And I think the bottom one is probably one of our biggest arguments for us is like, look, the way that we're trained as psychologists in the assessment diagnosis and the behavioral interventions and really the biopsychosocial model, when we add psychotropics to that, we are very powerful because I often will say, look, you can't spend 15 or 20 minutes with a patient and do a great differential diagnosis. And if you haven't done a great differential diagnosis and you're treating people, you don't know what you're treating. You're not even sure whether you're treating is the right thing. And so we really bring a lot to the table. Sarub, and I think I'm saying your name right, it mentions, I don't know if you guys saw, the psychiatry is the third oldest medical specialty. 45% are age 57 and up. So they're going to retire en masse over the next 8 years. We're going to have a real big party for them. So yeah, that's that net loss of psychiatrists. And one of the good articles, it's older now, I think it's like 2011 or something, is from Daniel Carlott, a psychiatrist from Tufts, who's been pretty supportive of prescribing psychologists, outspoken in that way, wrote an article, 45,000 more psychiatrists to anyone, and that's kind of good reading on this particular topic. Right now, states with prescriptive authority, you can read those there. Illinois is the only one that really has a different law. It's, you probably are aware of this, but it's more based on a medical model where there's essentially a 1-year residency or internship in which you rotate through, I can't remember if it's 12 or 13 different specialties. It's much more similar to 1 year of what I see in family medicine. And so it would be very hard to grandfather anybody into that system. You would really have to grow up through that system in Illinois to be a prescriber there and to meet their qualifications. However, New Mexico, Louisiana, Iowa, and Idaho have very similar laws. Iowa and Idaho are in the process of getting spun up with their regulations and to have people start prescribing there. In fact, the very first prescriber in Idaho, the license 001, is Dr. Mike Tillis, if anybody knows him. He worked for IHS for a long time, Indian Health Service. Unfortunately, Oregon and Hawaii have both been vetoed. They've been passed both houses and have been vetoed. There's multiple other states that are currently pursuing prescribing psychology regulations, scope of practice changes. We are here in Washington. I'm the chair of that task force. We're going to drop a bill in 2021. Nebraska is doing well. Ohio is going well. You guys probably know a number of other states that are happening. I know Texas is working on it. I just kind of know from the people that I talk to what's happening in those states, but there are many states who are looking at this, and my expectation is that we will continue to see the states allowing prescriptions to climb. I think we have reached a critical mass of having 5 states. When we only had 2 states with New Mexico and Louisiana, first of all, half the people in the United States couldn't find those 2 states on a map, and no, they didn't consider them real states. But with the addition of Illinois, the home of the American Medical Association, Iowa and Idaho, I think we've really gotten on the map, and I think this is going to be a game changer. At least I'm certainly hoping it is, and I'm really hoping that the VA, that we can actually push this through. If the VA starts hiring prescribing psychologists, that would be a major boon. All right, so just a little bit of background here. Don't know, again, how much you guys know. But there is a designation criteria for these programs that teach psychopharmacology to us, and that is important, especially when you're talking to a legislature about this. There's model legislation. That's what we are using. That's what most of the states have used, with the exception of some of the compromises that Illinois had to make. And I don't know if you're aware, but there are some practice guidelines regarding involvement in pharmacological issues, if you want to look that up, from American Psychological Association 2011. But otherwise, ethically, ethical guidelines are the same for all psychologists. All right, let's talk. This is kind of where I come in, which is I enjoy research. I write articles and chapters. Probably get in 1 or 2 a year. I lecture regularly. I do try to stay up on evidence-based practice, and I look at the practice guidelines. But there is a real difference between evidence-based practice and practice-based evidence. Probably something you've heard before, but I wanted to point this out because we're going to be talking about this throughout this weekend, which is often practice-based evidence precedes evidence-based practice, right? So, you know, the experience that people have working with very difficult or refractory patients, and they're trying different medications, and they find out, oh, hey, well, this combination seems to work pretty well. And then it becomes sort of a standard of practice, but it hasn't been researched very well. So there isn't a lot of evidence or backup in clinical guidelines to say, hey, this is a good medication combination for X disorder. So, however, your rationale for using this combination is more a standard of practice sort of argument, which is based on practice-based evidence. So often what is available in terms of evidence-based isn't all that's being done out there. I assume that most of you have Stahl's Prescriber's Guide, and if you take a look at his Prescriber's Guide, some of this practice-based evidence is stuff that you're going to see in the Pearls section on each of the medications in his. He's going to talk about some of these things, or you're going to see that these medications are being prescribed off-label for a variety of things that he lists in that book, which makes it, for you and I, a standard of practice. If it's listed in his book as off-label, that becomes standard of practice for us. And that tends to be evidence-based practice. Practice-based evidence versus evidence-based practice. Okay. So this is just shocking, really, when you look at some of the data on how many drugs, how many psychotropic drugs are being taken out there. Antidepressants being the third most common for this period of 2005 through 2008. Most frequently used medication by people 18 to 44 was antidepressants in that year, in that space of time, and I can only assume that it's probably gone up since then. These medications are all over the place, and look at a 400% increase in the rate of antidepressant use in compared to 88 to 94 compared to 05, 08. And then look at, if you're interested in child psychology, 11% 11% of Americans 12 and older are taking an antidepressant. So it's not just the adults who are taking this, we're seeing children and teens involved in this prescribing as well. Interestingly, given the clinical guidelines, only a third of people with severe depressions take antidepressant medications. And I could tell you that the clinical guidelines are clear that if you have severe depression with or without psychotic symptoms, first line is antidepressant medication. So there's certainly an under treatment there. And then you can read that next one there, that some people take these medications for a long time. And I don't think we really have an answer to the question, what sort of problems can we expect if people are taking these medications long term? Right now, the answer is we don't have any clear reason to think that it's a problem taking them over time. But that may change after we've had people taking them for some time, right? So we'll find out. It's not something we can answer really clearly. Just want to go over black box warnings. So you probably are aware of this, the warning on a drug, on certain prescription drugs. It's called black box because it's surrounded by a black box. When there's reasonable evidence of an association with a serious hazard with that drug, anytime that there's a black box warning on a drug that you're going to prescribe for the group that you are, if there's a black box warning for the group that you are prescribing to. So for instance, all of the antidepressants are going to have a black box warning for basically children through age 25, that they can increase suicidal ideation, all the antidepressants in that age range. And if there's a black box warning, you absolutely must provide that black box warning to the person you're prescribing this to, and document that you've done so, okay? Now, this is interesting. Sorry, I didn't put the date on this. Oh, this is not the one I was thinking of. Let me get to the next one. And you see this black box warning for antidepressant medications, 18 to 24-year-olds, just drop that down to basically 12 to 24, right? At any point which they can be cognizant, I would pay attention to that, that there is a risk for increased suicidal. And notice the word tendencies, or consider that ideation. Now, here's the problem, and here's the date that I was talking about, 2014. So you may be familiar with this, that the coverage and the warnings about antidepressants and increased in suicide, suicidal ideation. Well, when that came out, who was prescribing all of these medications, all these antidepressants? Well, most of them were being prescribed by family medicine docs, and the family medicine docs saw this information. And I shouldn't say just docs, family medicine providers, including PAs and nurse practitioners there, certainly are adverse, like the rest of us, to liability. And they saw that and they said, oh my gosh. And so a lot of them started not prescribing antidepressants as widely. Simultaneously with this, there was an increase in suicide attempts. So, you know, they talk about unintended consequences here. Remember, if you look at the, let me see if I have a slide on this. No. If you look at some of the comments about the, in the articles written on this black box warning for antidepressants, yes, supposedly there is and for some people there is an increased risk of suicidal ideation, particularly within the first 2 weeks of starting a drug or increasing a dose of an antidepressant. But that is an increase in suicidal ideation. There was no increase in attempts or completions of suicide. And the theory behind that is like, hey, look, if we are pulling people up from deep depression, we are just giving them just enough energy and cognitive power to sort of have some thoughts about suicidal ideation. But it's on the pathway to recovery that as they move through that into getting better. And so something you need to be cognizant about when you warn people about this, you want to be careful not to say, well, it looks like there's an increase in suicide among people who take this in the first 2 weeks, so be careful. Let me know if you feel like taking yourself out. That is not the way to discuss this with patients, right? What I say is, look, for your age range, and I don't work with children, so I'm talking about young adults here. There can be an increase in suicidal thoughts, or if you've never had suicidal thoughts, you can have some suicidal thoughts. And if that happens, I want you to stop the medication and let me know, but I want to let you know there's never been any increase in suicide attempts that we know of from this. And this is something we can manage. It's rare, it doesn't happen very often, but it can happen. And I will tell you that it does happen, and that I've had this happen. You know, I've been prescribing now every week, all the time. That's my primary job, is doing psychology and prescribing psychology. And I have had a fair number of patients who have had clearly some suicidal ideation in proximity to starting an antidepressant or going up on the dose. We switch the antidepressants, and it usually is not a problem for them. Now, this is different than, some of you are probably thinking in the back of your head, well, what about switching into bipolar? What if we accidentally gave an antidepressant to someone who has unidentified bipolar disorder? We'll talk about that later, okay? Speaking of black box warnings and atypical antipsychotics, we're going to go over, we have a large area that we're going to talk about, a large slide deck that we're going to talk about atypical antipsychotics. But I just want to mention here about the warning that you probably have heard of, it's pretty old now, about using atypical antipsychotics in elderly people with dementia. Essentially, the short issue with this is that it was leading to kind of all-cause mortality or strokes in patients with dementia, elderly patients. With that black box warning, I can tell you, any of you who are working with patients with dementia will know that many of them still get atypical antipsychotics as a strategy to manage behavior and problematic behavior. So, and part of that's because, you know, what are the alternatives? What else do we have? Well, you can give an elderly person a benzodiazepine. What do you think when you think elderly and benzodiazepine? I hope your first thought is heightened fall risk, breaking a hip, and later dying of pneumonia. I mean, that's kind of the worst case scenario there, but we do worry with our elderly patients on benzodiazepines. You gotta be very, very, very cautious with that. I have a question from Maribel. Did you say that you switch meds when SI arises? And my answer to that is yes, I do. So they still have the depression, right? And presuming that we've diagnosed them correctly. So let's say I start them on, I have a 22-year-old female that I've started on 20 milligrams of Prozac or fluoxetine. That's a normal start dose for that. And they come back and they tell me within the 2-week period, maybe 10 days later, they're alarmed. They've never had thoughts of self-harm before, and they're starting to have these sort of impulsive thoughts of like self-harm, nothing that they're going to do. They don't have a plan. And by the way, this is sort of a common amalgamation of a bunch of patients that I'm sort of putting together here. And so they, because I had talked to them, they say, hey, I got a hold of you because this thing did happen that you said might happen. And I stopped the medication like you said. And at that point, then I switch them to a different antidepressant. Now, fluoxetine tends to be, if you know fluoxetine or Prozac, you know that it tends to be a little bit activating. I'm going to switch them to something that's less activating, like Zoloft or Paxil, under those circumstances. Okay, and we'll talk about picking antidepressants and how to pick them. Then you give them the same black box warning. Hey, if this happens again, let me know. Right? We're going to talk about this. All right, I think I answered that question. All right, we're going to talk about the STAR*D trial. I understand you guys have spent a little bit of time on this previously. The pros and cons of this, there are cons and there are pros. I suppose the pros of the STAR*D trial, the sequence treatment alternatives to relieve depression, is that it was a real world attempt to look at antidepressant use and efficacy. So the reason why I like the real world part of this is when drug companies do a trial of a drug, They find, the 100 people in the world that have depression only and nothing else wrong with them. They don't have any medical comorbidities. They've never had anxiety. They don't have PTSD. They don't have any sleep problems. They only meet the diagnosis for depression, apparently. I don't know how they find these people. And then they study them, right? But as we know, psychology is messy. The comorbidities is the rule, not the exception. And so they had many fewer rule outs, and they were trying to do a real world assessment of how antidepressants work. So nice sizable N there, 2,876 patients. Aiden, I assume that's the N that you're aiming for in your dissertation, right? That was a joke. All right, ages 18 to 75 again. So look at that. We're not trying to restrict ages. 41 clinical sites. Here's what it did, and then this may be a review for you, but just a reminder of this. There were 4 levels, and each tested a different medication or med combination for 12 weeks, which, by the way, 12 weeks isn't that long, right? 3 months is not that long on a medication in some ways. So if they became symptom-free, so right, they're looking for symptom-free, looking for resolution, they could move to the next level of treatment, right? And there were 4 levels. So the start level was Celexa, citalopram, reasonable starting place for medication, relatively low side effect profile, relatively newer SSRI. At that time, I suppose escitalopram or Lexapro wasn't available. So here it was, they started with Celexa. If you got all better in that 12 weeks, yay, you're done, congratulations. If not, you were to switch to Zoloft, Wellbutrin, or Effexor, or you could add to the Celexa, the Wellbutrin, Buspar, or check it out, cognitive therapy. Yeah, good. And that's what we're faced with, right? When something doesn't work, when something doesn't work, we maximize the dose. I will mention that first, right? Don't stop halfway on titrating if they are tolerating it. We want to maximize the dose, and we'll talk about the maximum dose for Celexa, because the maximum dose that you can prescribe Celexa depends on age, based on an FDA directive and warning. So level 3, so I'm going to go back. You fail level 2, okay? Either you switch to Zoloft and it didn't work, or you added Wellbutrin or Buspar or cognitive therapy to the Celexa and it didn't work. You failed that. Now you're going to switch to Remeron, which is what? I know you're all collectively saying mirtazapine right now, or Pamelar, which is nortriptyline, which is an old-fashioned antidepressant, right? That's a tricyclic antidepressant. Or you can add a level 2 lithium or triiodothyronine or T3, right? So I don't know if you know about that, but you can use lithium or T3 as an adjunct to antidepressant for treatment-resistant depression. Good data on lithium, actually, on that, and we're using it at subclinical levels of lithium. The typical blood levels of lithium that we're looking for are like 0.6 to 1.2. And, we've got people well below 0.6 on lithium using it as an adjunct. Oops, I don't know why my slide went ahead. Probably because I talked too long. So the, now let me see here. My slide's moving around on me. So back to lithium. So you might add, say, 300 milligrams of lithium. A reasonable therapeutic dose that would get you a good blood level on lithium for bipolar disorder is going to be about 900 to 1200 milligrams. Okay, so it's just a small adjunctive dose of that. How often are lithium blood levels checked? We'll get to that when we talk about, it's a good question, and we'll get to that when we talk about bipolar disorder and mood stabilizers. But I will tell you, here's a little piece on lithium. You want to prescribe the immediate release first, and you want people to be stabilized on that dose for at least 5 days before you get your first blood level. Here's the trick with blood levels on lithium that people screw up all the time. You have to get a trough level. A trough level means that they need to get their blood level almost exactly 12 hours, pretty much as close as you can to 12 hours after their last dose of immediate release, okay? So once you nail down using that trough level blood level, once you nail down the dosing you want to do, so let's say that's 900 milligrams of lithium a day, and you're doing it in 300 milligrams 3 times daily for that 900. That's how you're prescribing it. And let's say they're at 1.0 is their blood level, which is a very reasonable blood level for the maintenance of bipolar disorder. And you're happy with that, then you can switch over to 900 of the extended release lithium, which is better tolerated and can be taken all at once at night, which is easier on people. But those are some of the tricks of measuring lithium that you kind of have to know. And always, 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 and I know I'm going off on a little bit of a tangent on lithium here, and I'll return to the STAR-D trial in a second, but these are kind of the pearls that you want to know. If you see somebody on lithium and there is a blood level, you must ask the question, did they get that blood level? Did they get it as a trough level? Because a lot of people, they know they're supposed to get a level, but they don't know they're supposed to get a trough level. And it's meaningless if you don't get a trough level, okay? Enough on lithium. So that's level 3. One more time, it's the switch to Remeron or Pamelor or adding lithium or T3. If you fail level 3, you get taken off everything and you're switched to an MAOI or a combination of Effexor and Remeron or venlafaxine and mirtazapine, right? And if you are if you're a fan of Stahl, you'll know that the combination of Effexor and Remeron is called, does anybody know the nickname on that? They can send it to me if you want to. You're in California, you should know this. California rocket fuel. Sounds good, doesn't it? Makes me want to take it. All right. So here's the results from the STAR-D trial. About 1/3 reach remission in level 1. First shot at that, and that word remission is terribly important, right? Remission, they're all the way better, right? Response, we used to aim for response, which is typically defined as 50% improvement in symptoms. This is remission. We're getting people all the way better, 1/3. On the level 2, 25% of people reached remission. In the switch group and the add-on group, about 33% reached remission. We're going to talk about that and that difference, that 8% difference there, and why that might be important and interesting to us. Level 3, switch group, 12 to 20%, add-on group, 20%. Level 4, 7 to 10% reached remission. You notice the numbers are going, the remission numbers are going down. We're going to talk about what this all means. It's kind of the summary of what we learned from the STAR-D. And this is with all the, the warts and problems and methodological issues that STAR-D and criticisms that we can level at it. But I think as a rough guide, it gives us some reasonable information. So about half participants reached remission after 2 treatment levels, about half. 70% reached remission after all 4 levels. So this is where when we say, well, about, I don't know if you ever say this, but about 2/3 of people respond to the antidepressant medications. This is where that data comes from when we say that. But let me tell you, there are very few people that are going to go through as structured and methodical of a stair-step fashion of trying medications as what you see in the STAR-D trial, right? I mean, this is very carefully orchestrated. But that's kind of where that data comes from when we say, well, about 2/3 of people get better. And remember, we're talking remission here, and that's a big deal. We're not talking response. That 70% number goes way up with response. And response, while it's not as good as remission, is much better than nothing, in my personal opinion. And I go back on that 70%, That's on medication. You know, this is why we need to be doing CBT with these patients or other therapy modalities, right? In addition to medication. Medication isn't the whole story here. So this is kind of some takeaways. If a first treatment, should you switch or should you add? Well, based on this data, it suggests that maybe adding another antidepressant medication may get you a little bit more traction, right? So when you're prescribing, you know, when you're facing that, well, should I switch medication? And by the way, we are not switching medications until we have reached the maximum FDA approved dose of these medications. And let me give you a for example. So if I start somebody on 20 milligrams of Prozac for, let's say, combined depression and anxiety, which would be very common for me to do, and at 40 milligrams, they don't have any intolerable side effects. They're tolerating it well, but they're not better. I'm not going to say this is a fail, and we're going to switch to another medication. Let's try something else, because I have not maximized Prozac. Prozac goes up to 60 milligrams FDA for depression and 80 milligrams for OCD. So it has a safety record that is reasonable at 80 milligrams. You know, I am not going to pull out the Prozac until I've tried it up to 80 milligrams with people to see if they're getting better, as long as they're not having intolerable side effects. And I can tell you that there are some patients that I've had that at 60 milligrams, they're 15, 20% better, and at 80 milligrams, they're 95% better. So we really have to go all the way through a trial of the drug to find out. The other reason you want to do that is because you don't want to piss off the next provider, because what happens when you prescribe Prozac, you get up to 40 milligrams, doesn't seem like it's working, so you pull it out and you try something else, and then it doesn't work, and you keep doing that. Down the road, when that patient meets you, and you say, well, what medications have you been tried on? They're going to say, well, I've been tried on Prozac. And you'll say, well, how'd that go? And they'll say, it didn't work. Well, that isn't necessarily true at all. Right? We don't know. It didn't work at 40 milligrams, but we don't know if it worked at 80 milligrams. I'm noticing a question about audio. Does everybody still have audio with me?
Mine is working.
Yeah, we're good.
All right, got lots of yeses. Glad you guys are still awake. All right, and you notice that odds of improving depression diminish with every additional strategy tried. So we're talking about an interesting group of people that I often end up trying to treat, and that you will end up trying to treat, which are treatment-resistant depression patients, right? Or people with treatment-resistant depression. I throw this in because we're psychologists.
I'm sorry to interrupt, but I think several of us lost audio.
Okay, let's see if we can't get it back. Let me do a check on audio, guys. I'm going to ask everyone to send me a yes or a no if you have audio. So I'm getting a lot of yeses. I guess, you know, technically, I don't know how you'd send a no if you can't hear me. Aiden, will you work with Sarup on trying to get his audio back up?
Sure.
Thanks. All right, I'm going to carry on because it looks like almost everybody, essentially everybody, still has connection here. No surprise, fewer side effects of CBT and time. This is true. You know, time to remission, one of the satisfying things about being a prescriber is that we can see results faster with medication, right? There's something very satisfying about the appropriate use of a benzodiazepine with a person with a panic disorder who are going to start on an SSRI. And while we're bridging them to therapeutic levels of that SSRI, we intermittently, appropriately use a benzodiazepine, which is helping them with their panic attacks and giving them confidence in the medication and the treatment and having some success it's very satisfying as a provider if somebody come back and go, wow, that really worked. You know, I'm doing better, I'm functioning better. But as we all know, also with CBT, you know, of course, in CBT, it takes longer because we're training people, right? We're changing people's thought process, the structure of how they deal with things, how their behaviors. We're changing significant things that have much longer lasting effects than a short-acting benzodiazepine, which teaches us nothing, right? So the combination is powerful. And just kind of want to say that as a kind of an editorial there. All right, so let's talk about, I'm assuming these are things you guys have gone over before. Is this something you guys are all familiar with? Yeses and nos are fine on this kind of the. All right, so mostly yeses on this. You can review this slide here quickly. So SSRIs, NDRIs, and SNRIs we talk about all the time, right? I mean, bupropion is really the only NDRI that we have out there. SARIs, we don't usually refer to them as SARIs, but that's trazodone and nafazodone. Most people don't see nafazodone. Has anybody seen nafazodone used? A yes or a no on that? Well, no, you don't have to do a no, but just the yeses. Has anybody seen it? Yeah, I got one. Janelle and Hardley from Abdullah. Yeah, you don't really see it much anymore because nafazodone or Cerazone has some liver toxicity issues, so people avoid it. I have one patient who's on max dose of Cerazone, 600 milligrams, because I inherited that patient from a 200-year-old psychiatrist on the East Coast who was still using it. And it works really well for this particular patient. So I've continued it, but I do liver function tests on a regular basis with that patient. The NASAs, you know, you got mirtazapine in there. We're going to talk very specifically about mirtazapine, and then the tricyclic antidepressants with which I assume you are familiar. SPARIs, vilazodone. We'll talk about how vilazodone is basically buspar plus an SSRI, and then vertioxetine, which we're really falling under the multimodal kind of antidepressant because it's basically the kitchen sink, like every neurotransmitter of interest gets hit, even if it's not interesting. And it has its role, has its place. So here's the SSRIs. If you haven't memorized these yet, you are behind the curve. So this is the bottom line. This is what I teach my psychology residents on a regular basis is, look, the tricyclics were good, right? I mean, they actually worked. On paper, the tricyclics are effective antidepressants, but in small overdoses, tricyclics can be lethal, right? I mean, so you can get a fatal arrhythmia or SAD de point and die of an overdose of tricyclics. So you got to be very careful about that. And that's one of the reasons the tricyclics dropped out of favor. And the other is their side effects tend to be pretty problematic. But tricyclics, as you know, I mean, we're using them for medication for insomnia because they're so sedating, right? Amitriptyline, the other name for amitriptyline is Elavil, which I think is just an absolutely hilarious marketing scheme. Called something so sedating Elavil. But they were good antidepressants and anxiolytics, but these two factors made the SSRIs more usable. If you can fire and forget, right? You can give somebody Prozac or Zoloft, and you know they're depressed and they have suicidal ideation, and you're worried, you know, they might consider an overdose. At least as a prescriber, you're not giving them something you think they're going to kill themselves on. They might get serotonin syndrome and get sick, but they're probably not going to kill themselves. And they're going to tolerate it probably much better than they were going to tolerate the tricyclics, meaning that they're going to stay on it longer. Okay. Sometimes when this is from Carmen, sometimes when psychiatrists are retiring, they load some patients with meds, then it's hard to change that pattern. Yeah, that's really true. And we'll talk about that. In fact, actually your assignment over the next 2 weeks, which won't be too big, is going to be addressing that very question. Therapeutic effect, you know, so this is, you know, in Stahl's essential psychopharmacology. This is what Stahl is going to tell you. therapeutic effect, and there's range in there because there's some evidence that some of these medications kick into therapeutic effect faster than others. For example, mirtazapine is perhaps more likely to have a faster onset, and theoretically Prozac would have a longer onset because of its long half-life. But this is sort of the general therapeutic effect. And what I tell patients on a regular basis is like, look, it's going to be two to 4 weeks before we really know how this is working for you. And my general rule of thumb is I'm going to increase your medication every 2 weeks as long as you're tolerating it and we haven't reached remission. And so you're not even going to know, right? So I tell people, look, it's going to be 3 months till we know how well this medication is working for you. With that said, I will tell you that people start to feel better sometimes in little areas. Some symptoms get better, maybe sleep gets better or interest improves or something within the first week or two. And I tell patients, look, I don't think that's placebo. I don't think you're, and even if it's placebo, I'm perfectly happy with placebo. But I tell patients, I don't think it's placebo if you're starting to feel better. It's okay. Now, if they take it tomorrow and they're all better the next day, that could be placebo, right? I mean, yes, that's going to be placebo. So, but placebo is our friend. That's okay. While we build this up in people's systems. Okay. Common indications for SSRIs. All of these are things that they're FDA approved for. But in true practice, we use all of these medications interchangeably for all of these disorders. So the SSRIs as a group are likely to cause these, have the potential to cause these side effects. I often tell my patients when I start a medication like this, like an SSRI, I'll tell them, here are the things that might be a problem for you, but I tell them about half the patients I have don't notice any side effects at all. And most of my patients that do notice a side effect only have one side effect, maybe two, and they go away for the most part in 3 days to a week. And that is true. Not evidence-based right there, but basically clinician practice-based information. But these are the sort of things that I warn patients about that they might have a problem with. Now, the things that go away in 3 days are everything except for weight gain and sexual dysfunction. Those things can be unfortunately longer lasting. The rate of sexual dysfunction in the SSRIs exceeds 50%. So if you start one of these medications and you don't talk to your patient about the risk of sexual dysfunction, you're doing them a disservice. People worry, my family medicine residents will say, yeah, but if you tell them that, well, aren't they less likely to take it? Yeah, it's maybe, but then you can have a real conversation with them about whether they should take it or not. And remember that about half of people don't have sexual dysfunction. And if you do, and this is what I tell people, look, if it turns out that this SSRI prescribed you resolves your depression and your anxiety and you're doing great and your sex life tanks because you have no libido anymore, there's something I can do about it. And we're going to talk about what we can do about improving SSRI-induced sexual dysfunction later on. Okay, so these are the sort of things that you want to warn patients about. Have a heads up. They're not going to be terrible, but you could get these side effects and they should go away for the most part. All right. You'll notice that I don't have weight gain on there, but a mild to moderate weight gain can occur with SSRIs as well. And there they are. There's weight gain. Okay. So I will tell you that a certain percentage of patients that see on and Zoloft seems to be a big offender for diaphoresis, sweating, right? Night sweats. I have patients who I start on that. Also venlafaxine or Effexor. Sweating has been an issue for some of those patients. Dry mouth is pretty common as an anticholinergic effect for many of the SSRIs. I really don't see anorexia very often with the antidepressants. I suppose Wellbutrin might be, well, it's not an SSRI, so we won't include that here. I love that, we have insomnia and drowsiness on this, so, take your pick, whichever you prefer. Comment here that a psychiatrist they work with will sometimes use the SSRI for its sexual side effects in hypersexual teenage patients. Yep, so we can use these side effects our benefit, right? Another question is Benadryl prescribed when certain side effects are present? Benadryl would be a side effect, would be a medication you might prescribe for EPS, extrapyramidal side effects, and we'll talk about why that is. It's a powerful anticholinergic. All right, let's talk about some pros and cons on our SSRIs here. I'm gonna quick check how we're doing here. We're actually at about break time here, so we're gonna take a 10-minute break here in a minute. I want a little bit of feedback. In the last minute that we have, I want you to shoot me a text here and let me know, how are we doing on pace and content? Is the content on target? Is it too hard, too easy? Am I talking too fast? Are we, or is this good information? Are we on target? Okay, let me know. And then we'll be back in 10 minutes. All right, thanks everybody.
Doctor, if it's okay, before going to the break, I'll just run the attendance poll.
Sure. Okay. Let's talk about the SSRIs and some of the pros and cons of using them. And really, on paper, the SSRIs are all essentially going to be relatively equal in terms of their ability to treat depression and anxiety. A rule of thumb with the SSRIs is going to be lower doses, and this is just a rule of thumb, it's not true for everyone, it's just a generalization. Lower doses for depression, higher doses for anxiety, and I think in practice you will find that to be generally true. I will often tell patients this so that I can do some expectation management, that your mood may start to get better before your anxiety does. How do you select these medications? Which ones should you use? Well, when when I train primary care physicians, I tell them they should have a handful of favorites that they like to use. When I train prescribing psychologists, I tell you, you should be familiar with all of these and be able to choose amongst them based on their likely side effects / advantages with particular patients. You're kind of going to try to match the drug to the patient based on the medication profile. The things I'm going to talk about here are generalizations. They're not true for every medication, whereas Prozac I tend to think of as a activating medication, and for most of my patients, it's either neutral or activating in some way. I've had patients who get incredibly sedated on Prozac. So it's not 100% of the time. Patients are individuals and they can have different side effects, but these are kind of in generals that you want to know about these medications. When I'm looking at a patient who is lethargic, has low energy, they're amotivated, Prozac is a good choice with them because I'm looking for someone who I'm certainly not going to make their lethargy or lack of motivation worse. I might make it better by giving them something that could potentially be activating and give them a little bit of energy. So I'm not going to give Prozac to somebody who's agitated or super anxious and doesn't sleep at night. That's not going to be my first choice. It may end up being the one I use with them that they're happy with, but I'm not going to start with it. With all the SSRIs, you have the possibility of sexual side effects that we've talked about before. We'll talk about how we deal with that. One of the things you might want to think about with Prozac is it may have a little bit longer time to onset. So is that a consideration in the patient that you're treating? One of the things I like about Prozac is that it does have that particularly long half-life, which makes it unique in that it is the only one that requires absolutely no tapering. Now, in general, my experience with the SSRIs is people sometimes just quit them and they do okay. Paxil being an exception, as it can have kind of a terrible discontinuation syndrome, but sometimes people can stop them. But in general, when we stop these medications, we reduce them by 50% every 3 days and then stop them. You can go slower if you want, but that's a reasonably tolerated way of tapering these medications. Prozac, if you've got a patient who isn't consistent about taking their medication or is likely to abruptly stop taking their medication, perfect medication for them. It's going to taper itself, and it's going to be much more tolerant because of the long half-life of fluctuations in taking the medication. Their blood level is going to remain more consistent over time. Okay, so some advantages on how you might use that. Paxil, Paxil has, don't use Paxil in adolescents. I'm not a pediatric prescriber, but there's plenty of evidence that this is not a medication that should be used in adolescents. Its risks outweigh its benefits there. With that said, I use Paxil regularly. It tends to be a more sedating medication. I give sedating medications at night, no surprise, right? And so if I've got somebody who's agitated, I'm particularly thinking of maybe some of my PTSD patients, I may consider giving them Paxil. It might improve their sleep. I'm going to avoid it for somebody who is sleeping too much. I'm not going to give it to somebody whose motivation is super low and energy is low. I'm going to try to tamp them down just a teensy bit with the side effects of Paxil. Now, Paxil probably has the highest likelihood to have sexual side effects or other side effects. We can see some effective flattening in that. And I don't know if you guys know when I say effective flattening, that can be true for any of the SSRIs. And what I'm really talking, when I talk to patients about this, I call effective flattening the zombie effect. I tell people I'm starting a zombie army and I welcome them. What they complain about is just, they say things like, well, I feel better, but I don't care, or I just don't enjoy things as much, right? Well, what we've done is we've increased serotonin, which is on a bit of a seesaw with dopamine. So we've reduced their dopamine to the nucleus accumbens, where all the fun stuff happens, and so we flatten them a little bit emotionally. Also can happen a little bit in the prefrontal cortex as well. Some of that cognitive flattening can happen up there as well. So that's Paxil. Paxil you need to avoid in general in women, in females of childbearing range, because it is the only SSRI that is category D, and I'm going to use the old categories for pregnancies. Category D, which is you should not use it because it can result in malformations or other problems during the pregnancy. Okay. Oh, and I forgot to mention, Paxil has can have a wicked discontinuation syndrome. I mentioned that earlier. A discontinuation syndrome on something like this is that when you stop the medication, if you don't taper it slowly, you can have a remarkable amount of anxiety, irritability, agitation, insomnia, etc. as a result. Zoloft tends to be a favorite of the family medicine providers that I work with. It used to be one of my favorites. I use it less often now because I really find that for me, for my set of patients, that they tend to get flat on this. That affective flattening tends to be a bigger issue for them on this medication. However, I've seen Zoloft have outstanding effects for patients for depressions as well as anxiety. It's a good middle of the road, solid SSRI. Okay, same risks of side effects. It's absorbed better if it's taken with food, although in my experience, that's not absolutely necessary. Okay. Celexa, citalopram. So this is probably better tolerated than some of the other SSRIs, than certainly any of the other ones that we've mentioned before. Celexa is a pretty solid medication. When I could use Celexa at 60 milligrams with my patients who were under 60, I found it to be very useful. The FDA came out with guidelines. You'll notice it says new. That's when I wrote this slide. It was new. It's not new anymore. I can't even remember how old that is now, maybe 6, 7 years ago. Came out with guidelines because they were concerned about prolonged QT issues with the dosing on this. And so they changed it that the max dosing for people over 60 was 20 milligrams. And the max dosing for those under 60 was 40. It used to be the max dose was 60. They did a really good study on after this FDA guideline came out through the VA, and they found that basically, regardless of whether your dose was increased or lowered, if you were on citalopram before the guidelines came out and your provider kept you on the 60 milligrams or lowered you, and they compared those groups, there was no difference in cardiac events between the two groups or all-cause mortality. So, nevertheless, because of these guidelines, if your particular patient has a cardiac event and you're prescribing 60 milligrams, then you have a liability, and so you probably shouldn't do that. So as a result, I use Celexa a lot less often now because I can't get the dose high enough to really hit some of the symptoms that I want to hit. With that said, again, I have subsets of patients who do really well on Celexa. I tend to find that for mild to moderate symptoms of anxiety or depression, Celexa works really nicely. It does seem to have fewer sexual side effects or issues with it. It is well tolerated in the elderly. In my patients who are over 60 or 70, I sometimes use 5 milligrams. I have a 92-year-old patient right now who's taking 5 milligrams of citalopram. Does a great job helping her with her this anxiety, this free-floating anxiety that she has. So the S-enantiomer of citalopram, because you gotta get it back on patent, is escitalopram, right? That ES. Escitalopram. So because it's the S-enantiomer, or theoretically the portion of the drug that is going to be more therapeutic, the active metabolite of Celexa, it should be therapeutically effective with fewer side effects. And I think that's probably true of Lexapro. If the question is, what is the SSRI that has the least likelihood of side effects, your answer should be Lexapro. It's pretty easy to dose. This is a 10 and 20 milligrams. Now, with that said, sometimes I do 5 milligram increments. People that don't tolerate medication, well, I might start them at 5 on this. But in general, you can start people at 10 and just jump to 20. It's a good drug. It's pretty solid. In my personal experience prescribing this, I find that Lexapro, sometimes I can't get it up to a high enough dose because I don't prescribe it over 20 to really hit the symptoms. And that would probably be a personal complaint that I have with the SSRIs, that some of the FDA limits on the dosing seem a little low to me. you know that that's an issue for me for both Celexa and Lexapro. And so again, I'm mild to moderate symptoms. I'm probably going to use these medications. And that's very specific to me. That's not based on data. That's based on my own experiences with these medications. All right. So just a little baby warning on SSRIs. The SSRIs can be kind of heart healthy because they do reduce platelet aggregation. Same thing that you might take an 81 milligram aspirin for. However, that's not so great if your patient's taking an anticoagulant, right? So if they're in the Coumadin clinic and you add an SSRI, I'm not saying you can't do that, but you can't do that without talking to the Coumadin clinic. So the way that I handle this is, of course, you need to be knowledgeable about the other medications your patient is taking, and if they're taking Coumadin, what I do is I contact the Coumadin clinic, tell them what I want to do. I want to start this patient on 50 milligrams of Zoloft, and then the Coumadin clinic will say something like, "Well, we'll go ahead and monitor them more frequently on this." It's not a huge platelet reducer, but it can have an effect in that way. And if they're on Coumadin, of course, everybody knows what anticoagulants are going to do. Like, right, if you know, the other name for Coumadin is warfarin, right? We use it as rat poisoning, basically to make rats bleed out if they ate it. So it's a blood thinner. We don't want that to happen to our patients, so we want to make sure that we're working with other folks if we prescribe this medication under those circumstances. All right, kind of just paying attention to and be thoughtful about that. This is the reason why sometimes your patients, you can tell them that they could get bruising. So patients might come back to very fair-skinned patients and start them on an SSRI, and they might notice that they're bruising more frequently, and this is why. It's not emergent. It's not something that needs any kind of intervention, but it is an explanation for why that might happen. Here's the understatement of the world, right? SSRI sexual side effects can be problematic for patients. In general, my experience has been that with my young active duty patients is they would rather be horribly depressed than not be able to have sex. And so we have to be able to have a way to manage that. The sexual side effects, what I have done typically for SSRI induced sexual side effects is I have added Wellbutrin. If you're familiar with Wellbutrin, the other name for Wellbutrin is what? Everybody should have just said bupropion. You know it's an NDRI, a noradrenergic dopaminergic reuptake inhibitor. It comes in, you can get it in an immediate release, you can get it in a sustained release, which is BID dosing. Everybody knows BID is twice daily. And you can get it in an XL, extended release version, which is once daily dosing. I often will give people, what we're doing is we're boosting dopamine, right? Because we think that part of the reason that people are having the sexual side effect, the loss of interest, is because of the depletion of dopamine in some key areas. We replenish that dopamine, we're thinking we might get that sexual, that libido back. And so that's why we're doing that. And I would say that for the majority of my patients who I add Wellbutrin to an SSRI, they notice that the sexual side effects get better, and it's generally an antidote. That is not true for everyone, but it is for many of my patients. And Wellbutrin, that SR, which is BID dosing, I just give 150 milligrams of SR in the morning, and don't give them an afternoon dose, just once in the morning, and it seems to deal with the sexual side effect, and then I'm not giving them more Wellbutrin than I need to. The pharmacy will give you pushback on that because they're going to tell the patients, what is your doctor doing? He's only giving, this is twice daily dosing, you're only getting it once a day. Got to warn the patients about that. But I find that it works well. Now, I have been lecturing on this very topic for a decade and pushing Wellbutrin. Recent data, if any of you guys are up on this, is you'll see that actually Buspar has the most data supporting it as an adjunct to treat sexual dysfunction that is SSRI induced. Buspar is bupropion, right? 5-HT1A partial agonist. So you can use that. I have started adding Buspar because the data seems stronger. I saw a good review in the Carlot report on this that kind of broke down some of the options for treating SSRI side effects. And Buspar outperformed Wellbutrin, and I've had good luck with Wellbutrin, so I use them both. Now, of course, you can use, Viagra, the phosphodiesterase inhibitors, Viagra, Cialis, etc., for ED, erectile dysfunction. That is SSRI induced. That is possible. You can also switch medications. Sometimes I switch the SSRI to something else and things get better. You can also consider doing a drug holiday. That's always fun to talk to patients about. You suggest a drug holiday and they think you're sending them to Amsterdam. That is not the case. A drug holiday is when you skip the dose for 24 hours. Now, I'm not a big fan of that one because the sexual side effect is actually pretty immediate with the taking of the drug. So that side effect is right away. So if you don't take the drug for 24 hours, theoretically, the side effect of reduced libido or ED would get better. But the problem with that is, sexual sex is super reinforcing. And so if you skip a dose and you're super reinforced for that, you're going to want to skip a dose more often, right? So that is not my favorite way to go. There's a couple comments here that I want to read. Let me get to those here. Let me see. Did he say 150 milligrams of Wellbutrin once in the morning? Yes, I did say that, of the SR, not of the XL. The SR is the BID dosing. The XL is the once a day. I have been using the SR. That is not based on data. That is based on my personal experience of that. Part of why I'm doing that is I'm trying to keep a minimum effect of that Wellbutrin because they don't need it. I'm not trying to add the Wellbutrin as an antidepressant or cognitive enhancer or anything else. I'm really just using it to treat a side effect. So I'm trying to keep the dose low and the blood levels low. Can you repeat? Yes, and I think I just answered the next one from Jason, which is dosing twice daily. So that's the Wellbutrin, right? Don't worry, we're going to cover Wellbutrin. I'm going to talk about how to use Wellbutrin. This is only how to use Wellbutrin as an antidote to the sexual side effect, okay? So we'll get there on how to dose Wellbutrin. And these are ones, in my view, as a prescriber, you got to know just right off. You just really have to know how these are dosed and what formulas they come in, because this is our bread and butter. This is the stuff you're going to be using all the time. We talked about tapers. We don't need to talk about that here. All right, Wellbutrin. Aha, foreshadowing. So we can use Wellbutrin for a variety of things, right? So if you want to use it for nicotine addiction, it's called Zyban. It's FDA approved for seasonal affective disorder. It's a very good, in my experience, antidepressant. You see, can we use it off-label for SSRI-induced sexual dysfunction and ADHD? I don't know if you know this, but Wellbutrin, it is used off-label for ADHD, right? I mean, it makes some sense. It's a reuptake inhibitor for norepinephrine and dopamine, right? Dopamine is a precursor to norepinephrine. And if we hit the right parts of the brain with norepinephrine and dopamine, then perhaps we can improve symptoms of ADHD. I have used it regularly over the years when I have wanted to avoid using a stimulant medication for ADHD. And when we talk about, I'm not sure we're going to actually, I don't think there's an ADHD section on this specifically, so we probably won't talk about that. But just as a heads up on that, stimulant medication is the preferred treatment for ADHD. But there are times when you don't want to use a stimulant in a patient who has a substance use disorder, a history of substance use disorder, addictions, known intolerability, hypertension, cardiac problems, stroke risk, etc. Right? I'm going to finish talking about Wellbutrin. I'm going to answer a couple of the questions that just came up. So when I'm looking to boost somebody's energy and motivation, I'm looking at, I want to use Wellbutrin. The problem that you have with Wellbutrin is that it can exacerbate anxiety. It picks people up. It gives you energy, gives you drive, gives you motivation. And picking up your energy is, if you're agitated, that means it can pick up agitation or anxiety. So one of my pet peeves is people who start anxious patients on Wellbutrin, because usually what that does is makes the anxiety worse. The patient then says that they have an allergy to Wellbutrin, which drives me nuts, because later on I may want to use it as an antidote for SSRI and do sexual dysfunction or for nicotine addiction or some other reason, and they think they're allergic to the medication because they had a bad experience. So in general, do not start Wellbutrin with anxious patients. You can add it to a patient who's depressed and anxious. If you're treating them very effectively with an SSRI and you need a little boost for as an antidepressant, if their anxiety is under good management, you can add Wellbutrin later without causing that anxiety to go through the roof for most patients. Now, Wellbutrin, it's sort of old, but Wellbutrin of the immediate release version, when it first came out, doses over 450 milligrams of immediate release were unmasking or causing seizures in people with underlying seizure disorder or some sort of underlying risk for seizure disorder. If you keep it under 450 of the XL or the SR, actually I think it's 400 of the SR, you're fine. However, with that said, I will tell you that if my patient has a seizure disorder or a significant head injury, I will not typically use Wellbutrin. Well, I won't use Wellbutrin. I just don't use it because their risk for seizure is high, and I don't want to put them at further risk for that. Okay. Common side effect is a fine tremor. That fine tremor, that you get with Wellbutrin, it's a dosing issue. If your patient gets a fine bilateral hand tremor on Wellbutrin, back the dose down a little bit, and that'll probably get better. Okay. And sometimes you're trying to manage get the tremor down and the dose high enough to be therapeutic. And don't worry, don't be afraid to go to 450 milligrams of the XL on the Wellbutrin. It's a very effective, very good drug. Let me take a look at these comments here. Okay, so let's see, Jason, I'm gonna read this. Do you know the mechanism why we treat the sexual side effect is because you're able to decrease the antidepressant? We think what's happening, the question that Jason had is, why do we think maybe adding Wellbutrin improves the sexual side effect? And it would appear there's a couple of places in which we think the sexual side effect is being caused in the nucleus accumbens and also in the brainstem. In the nucleus accumbens, we think the reason is that if we use an SSRI, if we increase serotonin, we are sometimes with the subtypes of serotonin that we're increasing, it puts the brakes on dopamine so that there is a less dopamine getting to the nucleus accumbens, which can result in a loss of interest, okay? That's part of it, and that's part of how I understand how to answer it. I hope that makes sense. What if a patient is on a stimulant for ADHD and an SSRI for depression? Would you still recommend Wellbutrin? I would be more cautious about that because that's a whole lot of dopamine. And that would not be a first place for me to go. I would be more cautious about that. I see Wellbutrin used a lot with self-reported ADHD. Yeah. Basically, if there's no history of ADHD in childhood, right? People think that they have ADHD, and you're really not sure. And that a good place to go is you can go with Wellbutrin. Another option, and we're not covering this really in this lecture, is an NRI, which is a noradrenergic reuptake inhibitor called atomoxetine or Strattera. Although I'll tell you, my patients often don't tolerate Strattera very well, and it's not as effective as the stimulant medication. But it is an alternative for your patients who cannot be taking a stimulant medication for whatever reason that might be. All right, good questions. Okay, SNRIs. I do not know how familiar you are with these. Of these medications that we're looking at here, I have used the first 4. I've never used Fetzima or milnacipran. I use Effexor a lot. I like it. Cymbalta, I find is in my clinical practice, I find duloxetine or Cymbalta to be quite helpful for neuropathic pain, fibromyalgia issues, diabetic peripheral neuropathy, but I find that it really doesn't work as well for depression or anxiety, whereas I find Effexor, another SNRI, works really well for depression and anxiety, but not so well for the pain issues. So that is always a push-pull for me. So you'll see me and my patients are going to be on Effexor much more often. They're going to be on duloxetine. Pristiq, new improved venlafaxine or Effexor, right? That's venlafaxine. Theoretically, fewer side effects with that. I haven't used it very often because it hasn't been on our formulary. Does everybody know what a formulary is? Does anybody want a definition of a formulary? Let me know if you want to know what a formulary is. I have one patient taking milnacipran or Savella. It's an SNRI, and it's, check it out, it's in that bold is for FDA approved. It's only approved for fibromyalgia. This is a complex patient, probably with some Axis 2 issues, who has PTSD and fibromyalgia and ADHD, et cetera, and had been on milnacipran previously, and it had worked beautifully for her mood, her anxiety, and her pain, and was taken off of it because the provider had just never heard of it before, so they didn't feel comfortable prescribing it. I switched her back to Savella. She's on 100 milligrams twice a day, and she's doing brilliantly on it. I'm very happy with it. She's my only patient who's taking that. A formulary is important because your formulary is essentially the pharmacy that you work with. So in my case, I have a hospital that I work with, the pharmacy, and I prescribe the drugs that our pharmacy has. The pharmacy has a committee that gets together and decides which drugs for which disorders they're going to purchase and have available. And that's based on a bunch of things. They want to, obviously efficacy is one of them. But if you have 3 drugs that are of generally equal efficacy to treat hypertension, and one of them is on patent and the other 2 are not, the other 2 are going to be cheaper and they work just as well, on paper anyway, then they buy those and they don't buy the drug that is on patent still, that is super expensive. And so if I don't write for antihypertensives, but if I did, and I ordered that medication, I would have to choose from the medications that are available on my formulary, right? So what's on formulary tends to be less expensive, particularly for the government, and therefore more available. So the Pristiq was on formulary, and so I could get it, but I had to demonstrate that my patients had failed at least 2 or 3 other similar antidepressants from different classes before I did something, which is I put in a non-drug formulary request that's called an NDR, non-drug formulary request. And that's when you're requesting what it sounds like, right? That you want a drug that's not on formulary, that's going to cost more, and you have to be able to justify why it's worth spending that money on it, okay? All right, let me look at this comments real quick here. Third-party payers have formularies as well as Medicare. Yes, they do, right? Right, so we get restricted, and it's what they'll pay for, right? What if clients are paying out of pocket? Patients who are paying out of pocket, they can get anything. They just can pay a tremendous amount of money. So if one option you have for patients, you can say, I'm going to send this to Walgreens for you. But if this is not approved for your Blue Cross Blue Shield or whatever insurance you have, then it won't be the normal deal where you pay a copay. it'll be the deal where you pay the entire price for the medication because it's not approved by the, I, as the prescriber, did not go through a non-drug formulary request with Blue Cross Blue Shield and get it approved so that they would pay for it, which is, by the way, is very hard to do, to get approved, that is. And if that's the case and it's not approved and I order it, yeah, they can go get it, but it could cost them $600 for a month's worth. I'm not seeing this particular slide. If you're talking about the slide on formularies, I'm just talking about that off the cuff. That is not that's not on one of these slides. Effexor. I like Effexor. Effexor is one of my first go-to. You mean the SNR slide? Could everybody see the SNRI slide? It starts with Effexor and ends with Fetzima. Are people seeing that? I'm on it right now, yeah. Okay, good. Like, everybody else saw it. I'm sorry you didn't see it. Maybe Aiden, you can help with that.
Doctor?
Yeah.
I was making the comment. I can see the slide, but the uploaded or downloaded slide deck on the e-learning page, you know, I print them out prior to, so I'm following along on both. And I just happened to notice that this section, I don't believe, is in the uploaded slides, which is typically what I study from. So I don't know if there's a discrepancy between those two. I'm not sure. Maybe it's just what I'm seeing, but I just happened to notice that. So I wanted to.
Oh, yeah, that's interesting because I broke it into 7 sections, right?
Okay.
So make sure that it's not in the next slide deck, you know, that it's not, you know what I mean?
Gotcha.
You didn't get them out over.
Thank you.
Yeah. So I like Effexor. I use it a lot. It does have a slight risk of increasing blood pressure. So for hypertensive patients, you do have to be cautious. And when I say cautious, what I mean is I'll talk to your primary care doc and I'll go, hey, I see that you're treating patient X with a medication for blood pressure, hydrochlorothiazide, or another medication. And what do you think of this? I'm going to add this. It could increase their blood pressure. Generally what they say is, let's do a 5-day blood pressure check after you start that medication and see if we need to make an adjustment in the antihypertensive. So it can be managed, but I like to co-manage that. Patients without hypertension, I don't worry about that at all. Okay. One of the reasons I like to go to Effexor first is because it has that noradrenergic component to it, which makes it less likely that people, in my experience, are going to have the sexual side effect. Sorry, so Cerazone and Deserel, and nobody even calls Trazodone Deserel anymore. I don't know if you guys ever hear that at all. I never do. I always just call it Trazodone. Trazodone, it's a great antidepressant, right? But nobody uses that way anymore. I mean, I don't know, maybe you guys see it being used that way, but I only see Trazodone being used off-label for sleep now. I use it for sleep, Trazodone. It does have, if my memory serves correctly, some risk for prolonged QT, but it's generally speaking safe in overdose, and it's non-addictive, non-dependency forming. It's a good sleep agent. It does take an hour or two to kick in, so you got to warn patients, this is not a benzodiazepine. You're not going to go to sleep in 20 minutes. Plan accordingly, taking an hour or two before bedtime. I dose it in 50 to 100 milligrams typically. I've seen people go higher for sleep, but I generally don't go higher than 100 milligrams. Theoretically, it synergistically works with the other antidepressants. So if I've got somebody on 40 milligrams of Prozac for depression, and they're not sleeping well, and I add Trazodone, theoretically, the Trazodone plus the Prozac can together work to improve mood, as well as we can see some improve sleep on that. I will say that people, I would say Trazodone probably is more likely than some others to cause sort of a hangover in the morning. So people feel a little bit run over in the morning from Trazodone. That tends to be dose related, so you can try to back the dose up to a place where they're still sleeping, but they're not feeling run over in the morning. But generally, that's sort of a cup of coffee in the morning sort of thing. See, I misspelled antagonism. Antagonism is my new word. And we're going to get around to talking about antagonism of 5-HT2A. 5-HT, remember, is serotonin, right? So when you antagonize 5-HT, you actually release dopamine, which becomes important to us later when we talk about atypical antipsychotics. But that's an interesting mechanism of action. Trazodone, we talked about this. Remeron, I like Remeron. Remeron, it has a niche. It's a niche drug. Are you guys yeses or no's, or just yeses? Are you guys seeing this? Anybody using Remeron? Are you seeing this used out there? Your patients taking this? Mirtazapine. So mirtazapine is, on paper, one of the best antidepressants and anxiolytics. It probably kicks in faster than some of the other antidepressants. It has two major side effects of interest, right? Everybody knows this one, right? It's weight gain and sedation. You need to know, it is paradoxically more sedating at lower doses than high doses. It comes in, myself a 10-minute warning here before we go to lunch break here. Hang on one sec, let me set my alarm. So, it occupies a very interesting place because of that. So let's see. Hey, Janelle, you said for CDCR, what is CDCR? So when you're working with active duty military people, you have to be a little cautious, right? If I make them fat and sleepy, they miss their PT in the morning, and they weigh too much and they get kicked out of the Army. So I have to be very careful with patients in that case. But think about some patients that you might want to use this sort of medication for. Patients, those kind of rail thin patients, or think about a patient who is unable to put weight on, maybe because they have they're going through cancer treatment at the moment, theoretically an eating disorder, although you got to be real cautious about that because that can cause all sorts of problems. But theoretically could be helpful in increasing appetite. And so anyone who you're trying to increase appetite in or cause to gain a little bit of weight, it's a good choice. And for anybody who's not sleeping well, and often those things can go together. Now, with that said, I have, it comes in 15, 30, and 45 milligrams. I often, for sleep, you can sometimes give this to people for sleep as an alternative to other sleep medications. And I have people cut the 15 in half to take 7.5 because it's super sedating. And then it synergistically works with their other antidepressant to boost mood. Remember, the combination of mirtazapine and venlafaxine, or Effexor and Remeron, is called California rocket fuel. Although there doesn't seem to be a lot of data to say that it's an amazing combination. It does work pretty well, but it's not amazing. So this can occupy an interesting place. There are patients that you really want to use mirtazapine for, and you kind of want to have it in your back pocket so that you can think about it. Right? People are sending the excellent for increasing appetite. Right? There are patients who they're looking at this. I have some elderly patients who they weren't exactly having a wasting syndrome, but they weren't able to put on weight, and they've got them drinking the the Ensure, the high calorie shakes and stuff to try to get some weight and calories on board. And we can add mirtazapine, which improves the mood that I'm seeing them for, their anxiety and their appetite as well, and helps them put on a little bit of weight. Yeah. It also comes in oral disintegrating tabs, which is good for people that have dysphagia or difficulty swallowing. You see the sexual dysfunction there, about 30%. Risk of agranulocytosis or neutropenia, so you got to keep an eye on the blood count. Let me see where we're at on Okay, we can get right through these last few slides and then we'll take our break. Viabrid or vilazodone, is anybody seeing this yet out there? The question on mirtazapine at the 7.5 milligrams, do I still see the same side effects? See more of the sleep side effect, but theoretically the other side effects should be dose related, so perhaps less. That would be my thought on it. So this is, so we've all been adding buspirone or buspar to the SSRIs to boost that serotonergic effect. And we're going to talk about partial agonists later, but it's that's what buspar is. It's a 5-HT1A partial agonist. You add that to an SSRI. Now remember earlier, we talked about how adding buspar may be the antidote to the sexual side effect, right? So you got a patient who you're really particularly concerned or has a history of sexual side effects on the SSRIs and they don't want to go there again, vilazodone may be the drug for them, right? So that might be one that you would consider. Buspar is FDA approved for anxiety, right? So comorbid anxiety and depression might be a good indication for vilazodone. I think I've only used this once or twice. Vortioxetine, Trintellix. Its old name when it first came out was Brintellix, but it sounded too much like something else, so they changed it to Trintellix. This is the one that's a multifunction drug. So it influences serotonin, norepinephrine, glutamate, acetylcholine, histamine. It does seem to have some benefit for cognitive tightening, right? So people who are complaining about depression-related memory issues or not being able to kind of keep their thought on track, et cetera, might be helpful for that. There's some thoughts about its use in those circumstances. I have used vortioxetine a few times, basically for people who have failed every other SSR, every other antidepressant that I wanted to try them on, and I've kind of dropped back to vortioxetine. And I've had some reasonable success with that. I think it's okay. So let me see. We're going to finish with this slide, then we're going to go to lunch. Just kind of want to throw this out here, some tricyclic uses because they're antidepressants, right? You can read these. We talked about insomnia. For those of you who are seeing kids, imipramine is used a lot for enuresis. It's like just incredibly anticholinergic, right? So it dries you up and you don't pee at night if you take that. Anafranil, I am dying to use anafranil for one of my treatment-resistant OCD patients. I haven't found the opportunity yet, but it appears to outperform the SSRIs, although the side effects tend to make it a little bit less tolerable for some people. Amitriptyline, nortriptyline, I won't go into a lot on this. We're using it off-label for insomnia and in particular for neuropathic pain, and I have seen it work wonders for neuropathic pain. It's amazing. People are you can use it for migraine prophylaxis. So you probably have seen topiramate used for that as well, but amitriptyline or nortriptyline could be used for that. You've got somebody who's an insomniac and has migraine headaches. Amitriptyline is a beautiful choice. Your only problem would be, remember on the tricyclics, that risk of lethality in small overdose. 10 of these pills could kill you. So this is not something you want to give a patient who is suicidal and has history of overdosing. But for a lot of your other patients, amitriptyline could be a great choice. And again, synergistically, it is an antidepressant, even at these low doses. If you add it just for its side effect of sedation, theoretically, synergistically, it could work with your other antidepressants to boost antidepression. So guys, we're gonna go to this next review. When we get back from lunch, we'll start at 1 o'clock sharp. So everybody's got 1 hour for lunch. Have a nice lunch. Get rested up. Get coffee if you need it, and I will see you all then.